NP anesthesiology newsletters, staying academically active, and her dedication. But the most important point, which I just love to talk and tell about everyone, she is a skilled anesthetist, but what empathy and a lovely coordination with the surgeon and the patient she can do. That's a very entrepreneurial spirit, which is very, very excellent and very, very impressive. So over to you, Harsha. Thank you so much for given time and talked about the subject ERAS, guidelines and practices. As being a gynecologist, we should also prime ourselves with such knowledge, and that is very, very important. So over to you. You can share your screen and you can start your presentation.
I would begin this talk by talking about the problem that we all can see and we all face. More so, my gynecologist friends, my obstetrician friends, and my office-based surgery friends. Slow recovery because of contemporary but traditional methods of surgery and perioperative care leads to a higher risk of infection and complications, a prolonged hospital stay, which puts a higher burden on the already burdened healthcare system, increases the cost of surgery, and also is associated with more postoperative care requirement at home, which is nowadays difficult, even in India. This perioperative care is now undergoing a paradigm shift, and we are coming into the modern healthcare systems as along the entire world. A very important question these days is, can you really afford a baby? In India also, somebody has compared babies with diamonds and said diamonds are cheaper. There have been papers where people have reported that bringing forth a baby and bringing the baby to life and raising the child to 6 months has costed them 4.5 lakh rupees and above. In India, a cesarean delivery carries a substantial out of pocket expenditure for all the classes and also, especially in private practice and also in government hospitals. Even in government hospitals, the healthcare system is so overburdened because of the sheer population that they do not get enough care. And that is why ERAS. Why does the topic matter? So I'm going to talk about the basics of ERAS, why it is essential, how we can implement ERAS in our protocols, and how standardize them. The Indian reality. Why do you need to actually adopt ERAS? We are the world's largest set of population and the largest set of patients, but a very small subset of healthcare resource. We are resource sensitive. Just as I said, even a cesarean delivery in India creates a major out of pocket expenditure for the patient, family, and also for hospital systems in the government hospitals. Caregiving at home is also not easy anymore because everybody's working. Surgical outcomes and recovery times are definitely shorter with ERAS protocols. So the whole concept started with an effort by Professor Henrik Kellett, who in 1990s started a small bundle of care in the name of enhanced recovery after surgery for urosurgical, gynecological, and then when he expanded them into general large surgical populations, also into cardiac surgery. Once this was successful, a proper ERAS society was established and they set out their first guidelines in 2005. The core pillars of enhanced recovery after surgery include early feeding, goal-directed fluid therapy, non-narcotic analgesia, and ambulation. This is a very common picture that you would see anywhere. I think the core pillar is patient education and engagement and deals with much more beyond these four pillars. So it's a huge passage moving on from the preoperative phase into the intraoperative and then leading the patient through the postoperative phase up to discharge. Why ERAS? What ERAS actually includes is in the preoperative phase, starting from counseling, selection of patients, correction of comorbidities, shorter periods of preoperative fasting, into the intraoperative period, opioid sparing anesthesia, optimization of how much fluid therapy you are giving, antiemetic prophylaxis, proper antibiotic prophylaxis, and then into the postoperative duration as early as possible. If you can start feeding the patient, mobilize the patient early, schedule non-opioid analgesia and rehab. A large meta-analysis that has been published in the Journal of Obstetrics and Gynecology shows that ERAS reduces the length of stay and opioid use without increasing readmission rates or maternal complications. They have also said that it is important that the implementation has to be protocol-based, it has to be team-driven, and it has to be audited on regular intervals with standard recovery metrics. Likewise, in gynecological surgery, it has been shown that ERAS protocols lead to shorter length of hospital stay, fewer complications, fewer readmissions, especially in gynecologic oncology. Gynecologic oncology also highlights the gap between evidence and real world uptake of ERAS. In gynecological surgeries, ERAS has been associated with an overall reduced cost of care in minimal invasive gynecological surgery as well. And just as I said, for India, the strongest direct economic argument is already high cost, even for a cesarean birth. So coming to the core concept of ERAS. ERAS is a multimodal perioperative pathway designed to reduce surgical stress and accelerate recovery. It is built across three phases. Sorry, I'm so sorry. Let's go. Preoperative, intraoperative, and postoperative. The goal being not only faster recovery, but also fewer complications and overall reduced cost. So this is a comparative table between traditional care and ERAS care. Pre-operative phase, the traditional care, we used to have prolonged fasting, 6 and 8 hours, overnight fasting, variable counseling. You know, uh, people used to explain things based on their own experience. But in ERAS, it is a structured counseling, shortened fasting periods. Intraoperatively, opioid-heavy liberal fluids and variable antiemetics were given, whereas in ERAS care, we shift to multimodal analgesia, we have fluid optimization, we have routine prevention of emesis and postoperative nausea vomiting. Postoperatively, earlier we used to have delayed oral intake and mobilization. Patients used to keep lying on their beds for 2 to 3 days, not eating anything, IVs going on, and then leading to thrombogenesis, DVT complications, etc. And with ERAS, early feeding, early mobilization, and a planned discharge is how we go. The outcomes, a longer stay, a higher cost burden, and lesser satisfaction, and with the traditional care compared to a shorter stay, lesser cost, and higher satisfaction rates. The pre-operative ERAS components include patient counseling and setting expectations, optimization of modifiable factors like anemia, sugars, blood pressure, fasting minimization, and carbohydrate loading where appropriate. Rehabilitation where feasible for high-risk patients. The ERAS Society has evidence-based recommendations for almost all surgeries depending upon the strength of evidence. However, let's come to the first point. Thanks to this gentleman, we nowadays have a larger epidemic than even COVID-19. The new syndrome called Googleitis. Every patient is so learned. So it is very important to select the patient and counsel your patient. Your patient might come with a meta glass and would have an answer and a revert question for every statement that you make. And that is why counseling and giving that time to the patient is very important. Well begun is half done, and you need to create realistic expectations with the patients. Optimization. Anemia is a very common entity in India even today. Hematinics in the preoperative period are generally not included. Nutritional deficiencies like B12, folate, and vitamin D, which are really very common, are most often neglected. And this leads to a poor recovery post-op and a requirement of higher blood products. Comorbidities that the patient would have, especially for gynecological oncologies, patients may be diabetic, their medical reconciliation has to be optimized. All their medication has to be taken into account, which medicine has to be continued through the perioperative period, which has to be stopped through the perioperative period. Everything has, and that is why you need a team over here. Many patients could have pain, and it is important to remember that it is not important to bring the patient to the OT table. It is important to bring a comfortable patient, as comfortable as possible, to the OT table. Anti-aspiration prophylaxis, as usual, is very important, just like in traditional medicine. I would want to talk about rehabilitation and management of sarcopenia because with advanced age, muscle mass reduces. Muscle is your second liver. I would rather say it is the first liver. It is very important in having good recovery postoperatively. Patients who have preoperative sarcopenia are bound to give you problem post-op, and that is why physiotherapy is very important in the preoperative period. I regularly encourage all my patients to do pranayam on the day pre-op and post-op as well. However, spirometry, yoga, or even physical therapy preoperatively can be instituted for patients who require it. The ERAS Society gives a standard preoperative recommendation, and these are very widely available all over the net, so anybody can refer to them according to their own institutes. This picture gives us a basic idea of what happens metabolically during starvation period and during the surgical stress. So when your patient is undergoing a surgical stress, the entire body goes into a phase of protein catabolism, gluconeogenesis, because of a high release of adrenocorticotropic hormone, because of the entire stimulation of the hypothalamic pituitary axis. There will be gluconeogenesis, there will be glycogenolysis, and a high glucose level. Also, there will be insulin resistance, and because of protein catabolism, kidney is also under higher pressure. Now, when you have your patients fasting for long hours, the standard NPO checklist says 8 hours for fatty foods, for normal milk or normal foods, 6 hours, breast milk, 4 hours, clear liquids, 2 hours prior to surgery. But one needs to remember that for most patients, when you keep your patients fasting for 8 hours, you are increasing glycogenolysis, gluconeogenesis, and insulin resistance. And this is going to create hurdles for postoperative recovery. Starvation leads to a lot of ketosis. And that is why the ERAS cycle says that you should carb load your patients before surgery. So on the day of surgery, a carbohydrate load is given to the patient as a clear fluid 2 hours prior to surgery. The questions that one would ask are, questions that one would ask are, do preoperative carbohydrate loading increase hypoglycemia? No, it may not increase the risk of hyperglycemia. In fact, it increases your insulin responsiveness. The other question that most would ask, does preoperative carbohydrate load increase the risk of perioperative complications? No, on the contrary, evidence has shown that it reduces the risk of complications. It reduces the risk of hypoglycemia, CVA, enhances neurological recovery. So, how do we carb load the patient? What are the clear fluids that are allowed? One may have a commercial pulp-free lemonade, apple juice, commercial iced tea, cranberry cocktails, or even simple coconut water. Simple black tea, black coffee with sugar is also fine. However, milk, juices with pulp, broth, soups, and obviously alcohol are not allowed. Now coming to the intraoperative components of ERAS. It is based on multimodal opioid-sparing anesthesia and analgesia, fluid optimization rather than liberal replacement. We call it goal-directed fluid therapy, active prevention of hypothermia and nausea and vomiting. Mind you, temperature management is a very important aspect of anesthesia and perioperative care because hypothermia has many more disadvantages and risk of complications than we think. Preference for minimally invasive surgical procedures wherever appropriate. The options for multimodal analgesia have been given here. Largely, we use regional anesthesia as far as possible, stick to non-opioid anesthesia and analgesia, and now there are very good infusions available, very good drugs available. Gabapenoids can be continued through the perioperative period. Local or regional anesthesia can be used. IV lidocaine is available. Dexmedetomidine is a very good drug and is a very safe drug, which we are using very commonly in our day-to-day practice now. Antibiotic prophylaxis. Yes, appropriate antibiotic prophylaxis within 60 minutes of the incision is very important and it is a key determinant of the risk of infection postoperatively in most patients. Preparation with chlorhexidine rather than povidone iodine. A blunt expansion of hysterotomy in cesarean section has been a very important key point in ERAS guidelines for cesarean sections. Closure of a hysterotomy in two layers. No peritoneal closure is advised now. In fatty patients where the subcutaneous fat layers are more than 2 inches, it is advised to suture this layer as well. Subcuticular sutures and staplers offer better healing than the standard traditional sutures. Perioperative nutrition and other care. Target euvolemia. Do not over transfuse your patients. Do not over infuse your patients. Goal directed fluid therapy is the norm and has shown much better results in most patients. Prevent hypothermia. Forced air warmers are freely available now, warming IV fluids, especially in old age patients and in children. Regional anesthesia, where applicable, in cesarean sections, the neonatal pathways have been guided, delayed cord clamping by at least a minute. Routine neonatal oxygen supplementation may or may not be. For the postoperative period, early oral intake and early mobilization. Whenever patients have not been given muscle relaxants, we even give them sips of water in the recovery room immediately after surgery. Patients who have not been given sedation and who are deemed not at risk of aspiration may be given early at least water, and after 2 hours, clear fluids can be started. Sham feeding is a very good concept where patients who cannot, even if you cannot start oral feeding early, Sham feeding can be done where a patient is asked to keep chewing the chewing gum for at least 15 minutes every 4 hours, and that is supposed to increase that motility. Multimodal analgesia with obviously opioid-free techniques if possible, planned early catheter removal and early discharge, monitoring the patient for ileus, postoperative nausea vomiting, pain management, and a functional recovery is the target. So this is a brief specific item slide for cesarean delivery, where again, education of the patient in the preoperative period is very important. Card drinks on elective sections, and obviously we all pay attention to the patient's hemoglobin. Spinal anesthesia is the preferred mode of anesthesia. Antibiotic prophylaxis. Earlier, we used to say that it is safer to administer the antibiotic after the baby is delivered. However, with the latest ERAS guidelines, they have recommended giving the antibiotic 60 minutes prior, within 60 minutes prior to the incision. Multimodal analgesia, non-opioid analgesia, goal-directed fluid therapy, skin to skin, which is really giving very good neonatal outcomes, late cord clamping, and the surgical techniques as we just spoke about. During the postoperative period, judicious analgesia, early mobilization, early oral fluids, and early discharge. For major general and gynecological surgery, bowel preparation avoidance has been recommended unless really indicated. Rehabilitation of high-risk patients, intraoperatively, minimally invasive approaches wherever possible, restricting IV fluids and laying more stress on oral fluids as early as possible, antiemetics, and regional blocks where applicable. The TAP block has been one of the best blocks that has been invented in the recent times. Most patients with tab block do very well after cesareans and hysterectomies. Even in major abdominal surgeries, tab blocks, the erector spiny plane blocks, they're all doing very well. Post-op, early oral intake, early catheter removal, protocol-based early catheter removal, DVT prophylaxis, especially in obese patients and patients with a high risk of DVT postoperatively, mobilization, early mobilization and early discharge of these patients. ERAS basically involves multidisciplinary team roles at different levels. So if I want to start adopting ERAS in my hospital or in my practice, what do I do? Do I have the baseline data of what are my traditional practices and what are the results? So how much fasting am I using now, pre-op or post-op? And what is the result in my patients? I need to have a basic data. Who are the local champions? You can contact hospitals and doctors who have been using ERAS guidelines in your area. You can consult them. Which ERAS items are feasible now versus later? So not all ERAS protocols may be applicable immediately or may not be easy to apply in your setup. So you need to understand which items are feasible for your setup and then gradually you can step them up. And how will you measure your safety? That is why a specific metrics has have to be designed, which you will be screening, like enteral feeding and postoperative IVs, like early mobilization or vis-a-vis late mobilization, like IV versus oral analgesics, regional anesthesia versus general anesthesia, advanced regional blocks for postoperative pain. So you can just measure your metrics. You can have predefined metrics by which you can actually see whether it is proving successful in your setup. This is a slide that shows a simple implementation roadmap. So you can have a baseline audit of your current protocols. So how are you dealing with your situation now? Form a local ERAS working group in your own hospital and decide upon what protocols you would be having. And for that, you need a multidisciplinary team. Develop your protocols, make patient document sheets, and most important comes training and retraining of the staff till it gets ingrained into their minds because the staff may go wrong. You may ask the staff to give the patient water 2 hours prior to the surgery, and the staff end up giving tea or milk. You may not even know, and the patient might risk aspiration. That is why it is very important to retrain the staff every now and have checklists at every step to make sure that all safety protocols have been followed. Early recovery after surgery is the goal, not a speedy, hasty accident. That is why we need to be very careful when we are implementing any ERAS protocol. What is advised is go slow, step by step, take one thing at a time, and then start optimizing, and you will have your entire thing in place. What are the common implementation barriers and failures? The most important is inertia of the surgical team. The uptake is often suboptimal despite knowing that there is strong evidence towards ERAS guidelines. Main barriers include lack of standard protocols in your own setup, a weak team coordination, and a poor audit system. Success depends upon protocol-based team approaches and a continuous monitoring. Lack of repeated training, just as I said, would lead to failure. Patient selection is very important. You need to know which patient, ERAS will not work everywhere. So you need to know which patient is a good candidate for following ERAS guideline. And once your standard guidelines, your standard protocols have been developed and in place for a significant length of time, then you can apply it to a larger group of patients. Failure of patient counseling is one of the most important reasons, and that is why pre-op counseling has been emphasized. Individual patient responses, some patients you may fail. So, patient complications are inevitable. They would happen. You can just reduce them. They may not be zero, but you can definitely reduce them. Thank you. Thank you, ma'am.